old gentleman who is an ex-smoker. He was actually referred to us from my own colleague from Hospital Muar. So this gentleman presented with the history of blackish stool for the last 2 months. And it was the first episode, and he claimed that it was intermittent whenever he passed motion. These symptoms is associated with abdominal pain and were described as colicky in nature. There was one episode of hematemesis of 1 day duration. However, he denies any history of reflux symptoms, dysphagia, early satiety, altered bowel habit, as well as tenesmus. There were no symptoms of anemia, and there were no constitutional symptoms of malignancy. So furthermore, he has underlying hypertension, which is well treated with amlodipine 10 milligram once a day. And he had one past surgical history in which an open appendicectomy was performed 40 years ago. He's married and blessed with 6 children. There were no history of taking aspirin as well as traditional supplementation. When he arrived to our hospital and we have assessed him and we found that him to be alert, there were no signs of anemia or jaundice. He doesn't appear to be cachectic. He's moderately built. Hemodynamically stable, and on abdominal examination, they were soft. It was soft, and there were no epigastric mass. However, there were right ballotable mass noted, and it turns out to be a right renal cyst. It was an incidental findings really, and bowel sound were present. It was normal. Per rectal examination showed there were no rectal mass or brownish stool. In terms of fitness for surgery, we deemed him to be fit. The assessment using the MET score was more than 4, and ECOG situs was 1. Showing here is the relevant blood investigation. Over here, we can see that it was fairly normal. The white cell count is 9. The inflammatory markers were not raised, 5.6. Renal profile, liver function test, as well as the coagulation profile were normal. So we have subjected this patient to perform an OGDS. And over here, there are 4 pictures that was taken during the OGDS. As you can see here, we can appreciate there was a submucosal mass located at the lesser curvature part of the stomach. And it is actually encroaching to the gastroesophageal junction. And this mass showed what we call as pathognomonic features of a gastrointestinal stromal tumor, in which we describe it as a central umbilication. And there's a presence of ulcer as well as bleeding from this mass. Upon completion of the OGDS, we found there were no similar lesion. The other part of the stomach were normal. Esophagus as well as the duodenum were also normal. And this is another view of the OGDS. It is actually a retroflex view of the OGDS. Again, it shows there's a huge submucosal lesion originated from the lesser curvature of the stomach. And you can see clearly that this mass is actually, extending near to the gastroesophageal junction. And again, I would like to stress here, this submucosal mass showed features of central umbilication and ulceration. So the next question is, should we biopsy this mass? So it is always a debatable issue here, whether you biopsy or not to biopsy. In my opinion, we will only biopsy a submucosal mass such as this only when we consider that there is a benefit for us to give a drug called imatinib as an upfront neoadjuvant. The purpose of giving this drug, there's a role to downstage the tumor so that at the end of the day, the aim of this disease is to perform an R0 resection. And I noticed that I'm sure within this webinar, there's a presence of medical students as well as even my houseman. For your information, R0 resection is basically the complete removal of tumor grossly as well as grossly. So this is our aim. Or in a condition whereby we think that the GIST were deemed to be unresectable or it has been metastasized. However, if you want to perform biopsy, it is recommended to perform using an endoscopic ultrasound guided. So we call that as an endoscopic ultrasound guided biopsy to increase the sensitivity of our biopsy. And there's a risk of tumor seedling, which we should avoid at any cost because it is deemed to have a worse prognosis for this patient. So over here, the picture attempt to illustrate to you about the mass. So this in endoscopic ultrasound, we can appreciate that there's an hypoechoic lesion originated from the submucosa. And ultrasound is sensitive. We can actually appreciate the layers of the mucosa. So we have, as part of our assessment, we have performed a contrast enhanced CT scan of the abdomen. And I'm delighted to invite Dr. Ho from the radiology department to enlighten us about the features of GIST and any other differential diagnosis from the CT scan. Dr. Ho, over to you.
Thank you, Dr. Nabil. So I'll be sharing my screen with all of you. So I'm representing radiology department. I would like to discuss the CT scan for this patient. So this patient, she had a contrast enhanced computed tomography done in August 2020. And the scan was done in other center, but not under HUKM. So from this cross-sectional study at the level of the liver at axial cut, we can see that's actually a well-defined heterogeneously enhancing mass centered in the gastric body with the location at the lesser cloacal region of the stomach, measuring approximately 5.5 times 5.5 times 5.3 centimeter. So if we look at it at a sagittal view, you just have a look at the red arrow. We can see from here, there's no obvious extraluminal extension of this mass. And usually if you look at the stomach, for this case, when the patient performed the scan, the stomach is not very well distended. But even so, you can see still see the hyper-enhancing mucosal layer, which is covering the mass, suggestive of a submucosal location of this lesion. And just to take note, there's an incidental finding of a large renal cyst in this section of the image. So otherwise, we also noted there are necrotic areas seen within the mass as indicated by the red arrow. And we have a closer look on the mass. You can see there's a track extending from the surface to the necrotic area, suggestive of the site of ulceration. Other findings includes there are small, well-defined hypodense liver lesions in segment 5 and segment 8 of the liver, suggestive of small liver cysts. There's no other focal enhancing lesions seen within the liver to suggest liver metastasis. So other findings from the CT includes no suspicious abdominal lymphadenopathy, no peritoneal deposit, no lung nodules in the visualized lung bases, and there's also no suspicious bone lesion. So based on this overall finding from the CT, we concluded that this patient actually have a submucosal gastric body mass with ulceration and necrotic component with no extraluminal extension, possible to represent a gastrointestinal stromal tumor. There's no evidence of distant metastasis at this time of the scan. So for GIST tumor, the most common site is at stomach. It consists of up to 70% of all the GIST tumor, and body is the most common site from the stomach. And it's closely followed by small intestine and less commonly in anorectum, colon, and esophagus. So the common imaging finding for GIST include submucosal location, and usually during the time of scan, the tumor size is already reached a large size. However, there's always no bowel obstruction seen. And some of the tumor will exhibit exophytic component as well. Areas of necrosis or cystic degeneration as well as ulceration is also one of the features for GIST. So some other atypical findings includes nodal metastasis, which is uncommon for GIST, and also aneurysmal dilatation of the small bowel, satellite tumor in adjacent soft tissue, as well as bone metastasis. So the most common site for GIST is peritoneum, followed by liver. There are less common site of metastatic involvement documented, such as in the soft tissue, lungs, and pleural. So according to a study by Marla et al., homogeneously enhanced lesion shows no metastasis for a mean period of 2.6 years follow-up compared to the heterogeneously enhanced lesion. And also, at least 50% of GIST have metastasis at the time of presentation. So our differential diagnosis for GIST includes adenocarcinoma, lymphoma, carcinoid tumor, metastasis, especially those at the gastric region with submucosal appearance such as melanoma and breast cancer, and other mesenchymal tumor including leiomyoma or non-GIST sarcoma, and also sometimes you can see neurogenic tumors such as schwannoma. So I have a diagram summarize an approach to the differential diagnosis of a solitary intramural gastric tumor. So based on this diagram, we try to find whether the tumor have an infiltrative margin and where's the location, and also presence or absence of a lymphadenopathy to narrow down our differential diagnosis. So for this case, that tumor doesn't show any infiltrative margin and the location is centered at the body. So it leaves us with the differential diagnosis of GIST, schwannoma, and carcinoid tumor. However, for this case, the size is more than 5 centimeters. Usually, schwannoma is not that big. For most of the time, it's not that big. So we rule out schwannoma. And carcinoid tumor usually is more enhancing, and we also have any other clinical features to support if it's a carcinoid tumor. So we came up with a diagnosis for GIST. So these are my reference for my presentation, and I thank you for your attention. I'll pass the mic back to Dr. Nabil.
Dr. Nabil, mute lah.
Sorry. Yeah. So we've already discussed about the CT scan. CT scan showed that it is resectable. So the next plan is actually to resect the tumor and for planning for surgery. So again, I would like to stress here that the primary modality of treatment is a complete surgical resection, whereby we aim for an R0 resection with 5 centimeter gross margin. In a case whereby the tumor is locally infiltrative, we have to perform an en bloc resection, means that sometimes the organs surrounding the tumor needs to be resected as well. Now, what is peculiar about this GIST tumor, it does not spread via lymphatics channels. Therefore, it is not necessary for us to perform a lymphadenectomy. And during operation, care must be taken not to avoid tumor rupture, as this will cause intraperitoneal seedlings, which essentially will cause grave prognosis for the patient. And for this case, we've counseled and we perform a laparoscopic proximal gastrectomy with esophagogastric anastomosis. And as part of the planning for surgery, we have to assess patient for fitness for surgery. And as I mentioned earlier, patient was an ex-smoker and he has hypertension but well controlled. And in terms of fitness for surgery, the ECOG status is 1 and the MET score is more than 4. It means that this patient is fitness for surgery. So a little bit about the surgery principles. Resection of the tumor can be performed via either laparoscopically or open. And as I mentioned again, grossly we have to resect about 5 centimeters, and there is a need for us to do a lymphadenectomy. And the reconstruction of the GIT tract is through esophagogastric anastomosis. So finally, we have counseled patient for laparoscopic proximal gastrectomy with esophagogastric anastomosis, KIV open. So over here is some of the pictures during the operation. First, we mobilize the stomach along the greater as well as lesser curvature. What illustrates here is the esophagus, and these two is a gastroesophageal junction in which we can see clearly the crura, the left and right crura. And over here is actually the hemoclips which have been applied before we transect the left gastric vessels. So after mobilizing the tumor, we have resected this tumor using an endogia stapler, 60 millimeter. And we can safely conclude that we have managed to get a good gross margin, and there were no tumor rupture during the operation. However, there were difficulty in for us to perform esophagogastric anastomosis, and therefore the decision was made to convert the operation to open. So this is the gross pathology of the tumor. So we can appreciate here that it is a well-circumscribed esophageal tumor with ulcerated central umbilication. And the tumor size is around 8 times 10 centimeter. And you can appreciate that this tumor actually arises from the submucosa. And we can see also here that there were no serosal breach in this specimen. So over here, I've shown to you about some of the studies, and over here is a meta-analysis comparing the outcome of surgery through two different approach, laparoscopic as well as open resection of JIS. And from this meta-analysis, they've concluded that both procedure will yield a good comparable outcome. It means that the oncological outcomes of resection will not be compromised. Another study by Chinese authors, they've compared between laparoscopic versus open wedge resection of this tumor of the stomach. It's a retrospective cohort study, and over here they've also concluded that laparoscopic wedge resection for this tumor is feasible. So post-operatively, patient recovered well. Initially, for a few days, we have kept this patient nil per oral, pending contrast study. We have started this patient on total parenteral nutrition to support in terms of nutrition. He had post-op lung atelectasis. I think it is aggravated by the fact that patient is a smoker. However, this condition resolved after an aggressive chest physiotherapy as well as in-situ spirometry. On day 6 of the operation, we've performed a contrast study. A barium swallow showed there were no evidence of contrast leak. So this is the final histopathological report. It confirms our suspicion that this is a GIST tumor. There's a presence of spindle cell. The margins, both the proximal and distal margin, were clear. However, based on this histopathological report, there are at least two unfavorable features of GIST, which I shall explain to all of you later. So over here, they have mentioned about there was a high mitotic count of this tumor of 10/50 high powered field. And the size of the tumor is actually more than 5 centimeter. And to enlighten us about what I meant by unfavorable features of GIST, as well as some other immunohistochemistry study that has been performed, I would like to invite Dr. Afiq from the pathology department. Over to you, Afiq.
Okay, thanks, Nabil. I'll share my screen first. Right, Assalamualaikum and good morning. My name is Afiq from the pathology department. I'll be presenting regarding the histopathological examination for this patient resected specimen. So what we received was a partial gastrectomy specimen. It has been cut open here, and as you can see, grossly there is a fairly circumscribed esophageal mass with central umbilication. As you can see, the overlying mucosa appears more flattened compared to the gastric folds at the surrounding tissue. So this tumor measures around 6.7 by 5.2 by 5 centimeter. And on cut section, we can see a fairly circumscribed tumor with 10 whitish cut surface and minimal areas of hemorrhage and some necrotic areas. There's no serosal breach here. And as you can see here, this is the overlying gastric mucosa, and the tumor seems to be arising beneath it. So on histopathological examination, this is the cross-section of the tumor. As we can see, it's a fairly circumscribed tumor abutting the muscularis mucosae, and overlying the tumor is the gastric mucosa. The gastric mucosa on high power view is lined by this foveolar epithelium, and then beneath it are some of glands lined by parietal and chief cell. As you can see here, the stroma is fairly edematous. And here again is the muscularis propria layer, and beneath it is the tumor. So for the tumor, predominantly it has a spindle cell morphology. As we can see here, it's arranged mainly in short fascicles, and this bluish area here is some of the myxoid changes that we can see in the tumor. So in areas, there are small clusters and nests of these more epithelial-looking cells. So basically, this tumor has a mixed morphology of both spindle as well as epithelioid component. This is another cross-section of the tumor. Here, the pinkish area in the center is the necrotic area surrounded by some edematous tissue. So on high power view, the spindle cell component, as we can see here, it's composed of this elongated nuclei, bland looking, with inconspicuous nucleoli. The cytoplasmic border is indistinct, and within a stomach gist, we can see what we call as paranuclear vacuoles, like this here, and this here. So basically, this is an artifactual change during fixation. For the epithelioid component, we can see compared to the previous slide, it has a more round nuclei with inconspicuous nuclei and eosinophilic cytoplasm. The background stroma again shows a myxoid stroma. So this is a high power view. What I want to highlight here is a mitotic figure. So this is one of the components that we must assess in a GIST tumor. So for immunohistochemical study, we did two stains, CD117, otherwise known as c-KIT, as well as DOC1. So basically, both of these are fairly sensitive and specific for GIST, particularly DOC1. For c-KIT, I'll highlight it a bit later. So the overlying mucosa here, overlying stomach mucosa here is not positive for these two IACs. So the diagnosis based on the histopathological as well as the immunohistochemical study fits the diagnosis of gastrointestinal stromal tumor. There were no lymph node sampled from this specimen. However, I would like to highlight there are a few components that we must assess in order to prognosticate this patient. Basically, this is a table taken from the WHO guideline. It's a United States Armed Forces Institute of Pathology, AFIP data. So there are three things that we assess mainly. First is the location of the tumor. Second is the tumor size, and then the mitotic rate. So for the location, it's either stomach or small bowel. As mentioned previously, there are other sites like colorectal and esophagus that can have GIST. So both of those are categorized under small bowel group. So for this patient, it's a stomach GIST, and the tumor is between 5 but less than 10 cm, and the mitotic rate is more than 5. The 5 millimeter squared here represents equivalence to 50 high power field. Basically, we'll choose a location of the tumor and we count 50 separate high power areas and look for mitosis. For this patient, we counted at more than 10 per 50 high power field. So these patients falls under group 6A. So basically, based on this, he has a 55% chance of progressing. So basically, it's defined as either metastasis or death due to the disease. So a little bit on GIST, it's the most common mesenchymal soft tissue sarcoma of the GIT, arises from the interstitial cell of cajal within the myenteric plexus of the muscularis propria, particularly the circular muscle area. So what interstitial cell of cajal do is it regulates the peristalsis of the stomach. So in GIS, there's mutation whereby there's perpetual activation of KIT receptor for the tyrosine kinase without ligand binding, resulting in the cell neoplastic cell proliferation as well as inhibition of apoptosis. So roughly around 80% of GIS have activating mutation in KIT proto-oncogene. So as you remember just now, I did an IHC for KIT, which is the CD117, and it was positive. So one of the treatment used for GIS is imatinib. Basically, it's a tyrosine kinase inhibitor, which blocks the intracellular domain of KIT receptor, thereby preventing downstream signaling of the cell growth. So the aim of imatinib is usually to provide disease control as well as prevent progression of the tumor. So with that, this is my references. I'll pass back to Dr. Nabil to continue his presentation. Thank you.
Well, thank you very much, Dr. Afiq. That was really informative. So as what is being correctly pointed out here, this patient fortunately has a few unfavorable features of GIS. And therefore, I think Dr. Afiq has actually explained to us what exactly is this tumor. So again, I would like to repeat, it is a mesenchymal type of tumor which arises from the interstitial cell of cajal. It is fairly a rare tumor, and based on the latest data, the incidence is about 1% or over 100,000 per year. And there's a slight prevalence in males over the age of 60 to 65 years old. And 80% of GIS were deemed to be benign. However, 30% can become malignant. And there are 3 subtypes that is known to be associated with GIS. They can be either spindle, epithelioid, or of a mixed type. And this tumor showed gene mutation. We call that as a KIT mutation of exon 9 or exon 11. So it is KIT is actually a proto-oncogene. So again, I would like to summarize that based on this case, there's evidence of hemorrhage as well as necrosis in the specimen. And from the histopathological analysis, there's a high mitotic count, and the size is actually more than 5 centimeters. So all of these are features that is unfavorable in this patient. So therefore, there's a role to start an adjuvant imatinib. And for that, before we start that, we have to follow up this patient, and the goals of follow-up for this patient is actually to detect if there is any relapses. And often, studies have shown that the relapses can be to the liver or the peritoneum, and the CT scan contrast is the modality of choice as it is sensitive enough to detect any evidence of recurrence. And as part of the discussion, I would like to say that ESMO or European Society of Medical Oncology has come up with a guideline, which I think is an excellent and very practical and easy to understand. This guideline has been published in May 2018. ESMO is a Switzerland-based non-governmental organization which studies on GIS. So based on this guideline, they have actually come up with the summary in a table form about the prognostic factors of GIS. So in this case, I've highlighted here that this patient has more than 5 centimeter tumor size, and there's a high mitotic rate, which is more than 5 over high powered field. So the algorithm here intended to show to you about the treatment of GIS in this patient. So in this patient, the surgery has been performed, and he has a significant risk of relapse in which he has a few unfavorable features of GIS. And therefore, it is justified for us to start this patient at adjuvant imatinib. And the recommended dose is 400 milligram once a day, and for the duration of 3 years. So what happens if the GIS is advanced or has metastasized or deemed unresectable? So it is based on this guideline, they have recommended for us to perform analysis, gene analysis, or to see if there's any exon 9 or exon 11 mutation. And they've recommended to increase the imatinib dose to 800 milligram once a day. And after that, we have to follow up this patient over the course of 6 to 12 months with CT scan. So during the course of follow-up, what happens if the tumor is not responsive to the treatment of imatinib? So we can actually use a second line multi-kinase inhibitor. In this case, sunitinib. If it fails again, then there's another third line of treatment. We can use regorafenib. So again, I would like to, before I end my presentation, this is the gist of my presentation. So again, GIST is a rare submucosal tumor. It can occur in the stomach or other parts of the GIT tract. If that happens, then we call that an extra gastric GIST. And the primary modality of treatment is still a surgical resection. Contrast-enhanced CT scan is sensitive in characterizing tumor as well as to assess the resectability. Both laparoscopic as well as open will yield similar oncological outcome. It will not compromise the tumor resection. And lymphadenectomy during surgery is not needed, as we understand that this tumor does not spread through lymph nodes. And during the analysis of HPE, it is important to perform immunohistochemistry analysis, which I think Dr. Hafiq have excellently described to us just now. And it is pertinent for us to see whether a patient has unfavorable features of GIST, because we have to decide whether the patient will benefit from adjuvant therapy with imatinib. Basically, the reason why we use imatinib is that we want to prolong the survival and to reduce the relapse rate of a GIST tumor. And imatinib is actually approved by FDA. I think it was approved in 2006 to be used in a gastrointestinal stromal tumor. The outcome that we are measuring is actually to reduce the risk of relapse as well as to prolong the survival for this patient. With that, I think I will end my presentation. If there is any question or if there's anything, I would like to invite the other panelists or my professor, Datuk Riza, to add. Thank you very much.
Okay, thank you, Dr. Nabil. Yeah. Okay, that was a good presentation together with others as well. I think there were a few questions on the chat box. Okay, basically one of it was to say whether it's a simple question. Okay, obviously it's not a simple question. Everyone used to wonder how do we remove specimens laparoscopically. Even so do I before I joined surgery. Even more after seeing all this bariatric surgery, I used to wonder how does Prof. Nick does it, and he does it so well. So basically in this case, when you're removing a tumor or a GIST tumor to maintain the size of 5 cm, prevent spillage, the best would be using an endobag, taking out through the camera port. Our camera ports mostly is about 12 mm. We can extend, make it slightly bigger, and we can take out the specimen in one piece without contaminating the peritoneum. So the next question would be, how do surgeons identify the tumor is confined to submucosal on gross examination? So basically, based on our endoscopy and our gross examination, we will see an elevated lesion wherever the sites are, especially in stomach. We will see an elevated lesion with surrounding normal mucosa with central umbilication. That is a part of necrosis. So that's how we identify grossly. More than that, of course, we need all the CT scans and EUS. Okay, so next is how do we get on Zoom talk? Okay. And is there any other questions? Good. Any other question?
Okay, dah. All right. So good morning, everyone. Very good presentation, Nabil. Thank you for that information. just to put things into perspective, this tumor is something that I guess is less of a bad news compared to the other cancers. Even in the worst of prognosis, it is still considered a better tumor than adenocarcinoma. So I always tell patients, I say, if you gotta have a cancer, something that patients need not fear. It is not a death sentence, and it should not be counseled that way. There are always neoadjuvant therapies post-surgery that we do all the time, and the outcome is a lot better than the other stomach tumors. So that's something that I wanted to share here today. So it shouldn't scare you all just because it looks big and it's exophytic or anything like that. It is something that we deal with all the time, and when it comes, it can come with a lot of different types of presentation. It can bleed, it can block, just like any other tumor, but the appearance is less scary because it's very smooth, submucosal kan. So kalau dia nampak scary pun, it's most likely because of the central umbilication where it bleeds. So that's about it. So it's not something that patients should be afraid of. It is something that has a better outcome compared to the other stomach cancer. So that's something that I just wanted to share. Could y'all hear me? Was I audible?
Yes.
Oh.
Dengar, Miss.
Okay. Does anyone else have any questions for us?
Dalam Q&A ada soalan.
Sorry, so one of the question was how do we prevent inter-observer difference in determining the mitotic rate? So for this, usually the guideline states 50 high power field, but for our case, we did more than 50 actually, roughly around 150 to 200. So basically we choose the area with the highest mitotic rate. So, and then to prevent further discrepancy, at least we can do 2 observers. So for this case, it was read by both me and Dr. Wahyuna, our specialist. So the count was fairly similar. Thanks.
I think there's one more question here. Maybe Mr. Sekapan can answer. By Prem Kumar Gopal. Good morning. Are there a standard resection margin for JIS?
Okay. So basically what you're looking at is resection margin. Of course, you want a complete clearance of the tumor, and the resection margin, as mentioned in the presentation by Nabil as well, it's about 5 centimeters. That's what we're actually looking for. So our plan of surgery based on the location might differ, okay? If it is at the greater curvature, we can even do a sleeve gastrectomy. If it is at proximal gastroesophageal junction, we can do a proximal gastrect. If it is at the distal stomach, we can do a partial gastrectomy. So that's how we plan as well. What is the latest news regarding?
I think the key is to get an en bloc resection. Make sure that we've got all the tissues that are attached to the tumor kalau dia infiltrating en bloc. So kalau dia infiltrating into any organ, then that one needs to be resected as well.
So basically, the other thing about resecting a GIST tumor, because like Ms. Renu mentioned, I mean, in comparison with other type of tumor, particularly epithelial origin tumor like adenocarcinomas or squamous cell carcinomas, it's much more favorable. And the fact that you don't actually...
The recording has stopped. This meeting is being recorded.
Can you hear me? Yeah, the fact that you don't actually require to remove or clear the lymph node drainage, makes the operation much more, is first and foremost is an R0 resection. So by definition, if you look at most of the guidelines, recommend a minimum of 1 centimeter resection margin, which will provide the best chance of getting an R0 resection. But of course, when we are dealing with a tumor, not only we want to remove the tumor completely, but also, if possible, we want to preserve the organ where the tumor lies, unless obviously it occupies the whole of the organs itself. So basically, the next aim is for organ preservation. So for example, in this case, the tumor was situated at the lesser curvature and close to the gastroesophageal junction. So we cannot just preserve the lower part of the esophagus. You have to take the lower part of the esophagus, unblock with the tumor, and have a much more resection margin in the distal side, because you have more stomach on the distal side. And of course, at the end of the day, the most important thing is you don't want to compromise the oncological resection. So if you have to remove more of the organ, then you have to, and that would dictate what sort of operation we have to do. So because this tumor lies at the junction between the stomach and the esophagus, so we have to resect the lower part of the esophagus and the upper part of the stomach. However, for example, if the tumor is very big and occupies a bit of the esophagus and virtually all of the stomach, then you have to remove the lower part of the esophagus and the whole stomach. However, you in order to restore the continuity of the GI tract, then the anastomosis, instead of, in this case, between the stomach and the lower part of the esophagus, then if you have to remove the stomach, then we have to use the small intestine, which is the jejunum, to join between the jejunum and the esophagus. So at the end of the day, the first and most important principle of any oncological operation is to make sure that we remove the tumor completely. Try and preserve the organ as much as possible, reconstruct with the best method so that we can reduce the morbidity. And of course, adjuvant treatment nowadays plays a role. And because of the advancing of science, there are not only chemotherapy available, we have biological treatment available as well. And more research are looking at imatinib for TKI resistant GIST tumor. So we're looking at especially KIT negative tumor, which accounts for nearly 5% of GIST tumor. So I think the research are looking at certain endothelial factor like VEGF inhibitors, which normally used in patients with KIT negative tumors.
Yeah. So there's one more question about outcome between laparoscopy and also surgery, open surgery, whether it affects the outcome, mortality, morbidity. So for GIST tumor, like we discussed earlier, there is no difference in terms of laparoscopy or open. The outcome is the same. It is as favorable as laparoscopy is as favorable as open, and the other way vice versa. So our preference is always to go in lap first as minimally invasive surgeons. The margin, as Prof said, is about 1 centimeter. So we don't really need to do as much resection. We don't need to do lymph adenectomy, which also reduces the morbidity for the patient, because the more you dissect, the more you resect, you know there's more complications that are potentially that can potentially arise. So there is, to answer the question simply, there is no difference between lap or open. It is the same in terms of outcome, in terms of morbidity and mortality. It's the same. In fact, I suppose in terms of pain, if one were to look at quality of life, I'm not sure if there are studies on quality of life, laparoscopy versus open for GIST. I guess it would be a no-brainer to say that laparoscopy would supersede the open surgery, because obviously there would be less pain and faster recovery for the patients. So there are no other questions from the panel. Can't see any other questions. Let's check. So if there is no other questions, shall we wrap up the CPC for this morning? Nabil, are you here still?
Yes, Ms. Renu, I'm here.
Okay. Any take-home message from any of the speakers today? Anything to say before we wrap up?
For me, I think, this is a good case from the patient. I think what we can learn here is that GIST tumor, it is a tumor, but it behaves differently from adenocarcinoma. And the fact that we've discussed about the incidence, whether we should biopsy or not, the approach of operation like laparoscopy of open, as well as the histopathological analysis. I think we hope that we can actually learn something from here, especially I learned a lot from this case, and I hope this presentation today have actually enlightened us about the GIST tumor in the future.
Okay. So thank you so much to all the speakers today. Thank you to everyone who is present. Sorry for the glitch early in the morning, but we're glad you're here with us till the end of the show. So see you in the next CPC. Thank you and have a great morning ahead.